Hi, this is Dr. Steigmann from Heidelberg, Germany. Today I'm going to give you a small presentation about the prosthetic soft tissue development, which is absolutely necessary in the world of implants today. Prosthetic soft tissue development around implants has the purpose to create or maintain a prosthetic scaffold so the implant emergence has a natural appearance for a long period of time. The goal is to give a structured approach to the soft tissue development from a surgical and a prosthetic point of view. The situation today is that we have a lot of technology, but this technology has to be applicable in the right way. And the benefits will be that we will have a beautiful emergence profile, soft tissue architecture, and we can maintain the soft tissue thickness and appearance for a long period of time. In conclusion, by the end of this lecture, we will have some hints how to achieve a beautiful emergence profile. I come from Heidelberg, Germany, where I have a dental office and a teaching institute. It's a city with the old tradition, and we are trying here to get all the pieces of the puzzle according to the soft tissue management. Our logo is two thumbs under the chin, which means think twice. Think twice is thinking first over the bone or about the bone, and the second is the soft tissue. And in the last couple of years, we realized that thinking about soft tissue has become a very important topic when we talk about aesthetic implant dentistry. In our institute, we have a lot of participants which come to our courses to learn how to work with the soft tissues surgically for bone grafting and aesthetics, and prosthetically for a better emergence profile and for understanding the biological changes of the soft tissue over time. What is our goal? Our goal is to have the same aesthetic outcome which we have with natural teeth, also with implants. We realized that in single implants, usually the literature shows that we have a recession after we put in the abutment or after uncovering and placing the abutment and the crown. However, we learned how to overcome these problems by trying to avoid any surgery which might injure the papilla or the gingival margin. And in a single tooth environment, we worry less about the papilla when we have good anatomical condition, and we worry more in the last couple of years about the midfacial recession. When we talk about multiple implants, full arch restorations, which you can see in the lower pictures, then we worry about the midfacial, but also about the papilla, which we have to create or maintain between two implants, between an implant and the pontic. So what we saw over time is that we want to have the same aesthetic result with single implants and multiple implants like with natural teeth, but the biological changes around implants over time are different than around natural teeth. So we come back to the same conclusion that implants are not teeth. That's why we have to define new parameters, how to do the surgery around implants, and also how to develop the prosthetic components for maintaining a good environment for the soft tissue and to overcome the biological changes which occur after implant loading. So when we look at different kinds of emergence profile, we will see that we can achieve a good emergence profile between implants and a pontic. We can achieve a good height, papilla height between the implant and the pontic. but also we can achieve a good papilla height between the implant and the natural crown. However, like we can see in the second picture on this slide, it's much more difficult to achieve what we can see here, the same level of papilla between two adjacent implants, which is similar in height than between a natural tooth and an implant. To achieve the same result, we have to either try to over contour in height the interproximal bone, or to trying to maintain after extraction the soft tissue at the initial level, although we're going to have two adjacent implants. This goal seems to be much more difficult when we have two adjacent implants than if we have one single implant or full arch restoration. When we have multiple adjacent implants, it's much easier to have good width of keratinized gingiva, but you can see in the third picture, especially in the posterior when it's not necessary, that the interproximal papilla is difficult to achieve after the patient was edentulous for a couple of years. However, in the last couple of years, we developed techniques to make a prosthetic scaffold so we can develop a good emergence profile and create an illusion of a similar architect like that of the natural dentition, especially when we can alternate implants and pontics, but also when we have multiple adjacent pontics, but also when we have multiple adjacent implants. So let me take you through some techniques or some thoughts we develop when we talk about creating the soft tissue emergence profile from a prosthetic point of view. The question which was over time is what should support the soft tissue in the transition zone? This transition zone, which some authors call the dual zone, it's the zone from the platform of the implant to the gingival margin facially, but it's also the zone from the shoulder of the implant to the peak of the papilla or to the peak of the future papilla. So over time we came to the conclusion that it's much better if we have an abutment which can be made out of a stock abutment or a CAD-CAM abutment, and this abutment should maintain the soft tissue. Because what we saw in the last years in the literature, that the problem seemed not to be the management of the papilla anymore, especially when we have good interproximal bony support, and we know that by making the good contact points and the right emergence profile, the soft tissue will return to the initial position. Problematic seems to be the mid-facial gingival margin. By having a good contour or of the emergence profile, giving enough space for the soft tissue, we might prevent soft tissue recession. But still we are in the trial and error period, and we saw in the literature, but more problematic seems the mid-facial gingival recession. So the question was if we can do an immediate implant placement to maintain the bone as we used to think in the past, but more than that, if we do an immediate restoration or a delayed restoration. De Rook and his collaborators in COIR in 2009 were showing that if we do an immediate restoration, we can diminish the mid-facial recession compared to a delayed restoration with 2.5 till 3 times. So there was a tendency to place implants immediately, try to avoid any surgery which might impinge on the papilla height or on the gingival margin, and then by making an immediate restoration to maintain the soft tissue contours. So when we go into the emergence profile developing, we have to look at the emergence profile of the tooth, the changes of the emergence profile when we talk about implants. we have to address the midfacial soft tissue and the biological changes for the midfacial soft tissue over time, but also color, chroma of the soft tissue, and the interproximal papilla, which will give a good emergence profile. So we have to think about an abutment design which should maintain the soft tissue, and the crown design which will maintain the soft tissue minimalistic, maybe 1 millimeter under the gingival margin. So we will have to think about an abutment design which will be ideal for the soft tissue support, a ponting design for aesthetic soft tissue development, emergence profile design for crown and abutment, then different wax-up modalities. We will do different aesthetic trains for different therapeutical phases, and the crown margin definition has changed over times. It used to be a time when we used to put the crown margins on the shoulder of the implants with specific implant systems, but today we know that it's good to keep the gingival margin as far away from the implant shoulder as possible. And then we can change and adjust the gingival management with temporaries and mock-ups according to our needs. So, with the help of new technologies with CAD/CAM, but also by modifying stock abutments and by understanding the new designs of emergence profile, we can improve a lot the way the soft tissue will look today. When we look into implant restoration versus the natural tooth, we see that we have a zone which is different. First, in the case of backward planning, we plan first the crown, which will be the final result, then the implant positioning according to the crown, but it's very important to understand that we plan for the beginning for the transition zone, and then the soft tissue support could be similar to that of the natural tooth, because in a natural tooth, this transition zone maintains the soft tissue. But when we talk about implants, or when we refer to implants, we have to understand that this transition zone has to be different than that of natural teeth, especially when we take into account the biological changes. And this transition zone will then maintain the soft tissue, give the natural appearance, but also try to maintain a soft tissue thickness which can resist to the future biological changes. So when we talk about this transition zone from the implant shoulder to the gingival margin and to the peak of the interproximal papilla, we have to have a structured way of approaching the soft tissue. First, the surgical of this transition zone is a way to preserve the soft tissue thickness, to preserve the initial structure and architecture of the soft tissue, or to regenerate the soft tissue from midfacially, but also the interproximal papilla. Then, if we can maintain and preserve from a prosthetic point of view, we can make temporary crowns and restore immediately a placed implant with immediate soft tissue support, or if we have a collapse of soft tissue, or if we have a recession on the midfacial, we can still correct it interproximally for the papilla, but also midfacially with a scaffold, with a prosthetic scaffold, which will recreate the soft tissue in the transition zone with the help of a good anatomy, but also when we have lack of interproximal bone. So now when we look, what can we do to preserve? When we talk about preservation surgically and prosthetically for the midfacial soft tissue, but also for the interproximal papilla, we talk about immediate soft tissue support. This soft tissue support of the transition zone can be with a temporary, which is placed on an implant, but it also can be with the help of a Maryland bridge, which is made in such a way that it might support the soft tissue from collapsing after tooth extraction. If extraction has happened and we have a flattening of the midfacial soft tissue and also of the interproximal papilla, we can recreate or develop the soft tissue by creating a scaffold for the soft tissue development, again for the papilla but also for the midfacial soft tissue. So we have to prepare every case prosthetically and surgically in time. So, from a prosthetic point of view, we have to create a priori a healing abutment, a temporary crown, when we try to preserve the soft tissue. We can use the natural tooth or an implant. That means we extract the tooth, we can cut the tooth after extraction at 3 millimeters from the CEJ line of the tooth and hollow it and then place it on the implant, or we can create a Maryland bridge according to Frank Spear's concept so we can maintain the soft tissue before collapsing. So in this case you can see that after extraction of the tooth we have interproximal soft tissue which is not supporting by the underlying bone, so we want to preserve the soft tissue at the same level. In this case, we are using a tapered plus implant from BioHorizon, which has a laser lock shoulder, but also a bevel, so it can engage with the soft tissue. We extract the tooth, we hollow it out, and then we're gonna glue the tooth on the abutment, and the soft tissue will, and this abutment will maintain the soft tissue at its initial position. After positioning the implant in the position of the cingulum or between the incisal position and the position of the cingulum, so we can avoid or prevent future buccal bone resorption, we can then hollow the tooth and glue it onto the abutment with the help of composite. So you can see after we can do that, we can make an impression, individualized impression, to transmit into the lab the soft tissue contour for the final restoration. What you can see in the X-ray is the natural tooth, which has some composite filling, glued onto the abutment and screwed into the implant. In this way, if the implant has a good primer stability, we can maintain the soft tissue contours over time with the help of an immediate implant placement, and with the help of a natural tooth we can maintain these contours. So the patient leaves with a fixed restoration with a screw retained natural tooth on the implant, which can be removed and repositioned on the implant. What's nice that we can adjust the natural tooth structure according to our needs, and the fixation of the natural tooth on implant is done with the help of an index. So you can see in these pictures the day of implant placement, the tapered plus laser rock implant, the gap between the implant shoulder and the buccal bone, which is filled with grafting material, and then after 6 months the soft tissue profile improved and maintained as a specific thickness which is needed not only for the immediate aesthetic outcome but also which will avoid biological changes and thinning of the soft tissue. By comparison, you can see that the soft tissue thickness after 6 months is thicker than with the natural tooth. So what we did in this case is that we reduced the buccal thickness of the natural tooth. We under-contoured the natural tooth when we screwed it into the implant with the help of the abutment. And then we can prepare our cast for the final crown. And these casts are prepared by placing the gingival margin 1 millimeter more palatal, or the abutment 1 millimeter more palatal than the gingival margin itself. So in time, this will lead to a thickening of the soft tissue. After we pour our cast, we will have the lab technician sign in or make a sign so we can know exactly where the gingival margin is, and then 1 millimeter posterior we will have the positioning of our abutment. This abutment can have different shapes. The design can be concave, straight, or convex depending on the implant position. To reach this position of the gingival margin from the position implants and according to the implant depth, we have to create different emergence profiles. So what you can see in this cast that we are trying to resemble or to mimic or to emulate the gingival margin of the adjacent tooth. However, we don't try to emulate the design or the cross section of the design of the crown when we do our emergence profile manipulation. Then we will have to take care of the proportions of the tooth, and if the tooth should have similar proportions and mimic that of the natural tooth in width and height, sometimes this will have to be overlapping of the natural crowns. After we look at the proportions, we can go ahead and fabric our final IMEX crown. What you can see in the middle picture is how much the natural tooth with overlap, because by overlapping we can change the appearance of the midline in this case, and the appearance of the midline can change the face aesthetic of the patients. So beforehand, before we even try to go to the patient's mouth, we will see the proportions, the emergence profile, but also according to the papers published by Chu, we can calculate the position of the contact point and the growth of the papilla, which will be less than 40% of the length of the visible crown from the incisal edge to the CEJ line. And what you can see on the left picture is where we presume that our papilla will grow according to the total length of the crown. And then the right picture, we can see the structures of the soft tissue, the overlapping of the natural crown over the adjacent tooth, and how we can manipulate the midline or the optical illusion of the midline in this case. After preparation and finalizing the tooth, you can see the position of the implant is exactly in the position of the cingulum. We have very good soft tissue thickness. In time, the soft tissue will thin out, so we want to have more than 2 millimeters or 2.5 millimeters of the soft tissue. And then we can look at the contact points, which can be placed palatal if the crown design doesn't allow us. But you can see that the emergence profile is under contoured but still straight, as the implant positioning is between the incisal position and the cingulum position in this case. By using implants with platform switching, we can increase the soft tissue thickness and can maintain it over time. And by doing that, we can avoid future recessions. We know that after extraction, the nutrition which is coming from the periodontal ligament will be abolished, and the only nutrition of the gingival margin will be by supraperiosteal blood vessels. So we will need an extra amount of soft tissue to be maintained in time. And by having this implant specifically here, the Taper Plus BioHorizon has a platform switching design. And in addition to that, it has some laser lock surface which will adhere, to which the soft tissue will adhere, reduce the probing depth, and give a very good protection of the underlying bone by thickening the soft tissue, and also by having this connection of the soft tissue with these modern surfaces. Now, when we look at these modern surfaces, it's very interesting that we can use this kind of implants to place them at the level of the bone, below the level of the bone, or above the level of the bone, as we know that these surfaces have a dual function, also having a connection at the soft tissue, but also achieving osseointegration when this implant is placed under the osseous crest. So when we take a look at the X-rays, we can see what's happening at the bone level, but also what's happening interproximally. And if we take a clinical picture, we can see that in cases like this, we can maintain the soft tissue by placing a natural tooth immediately, but also maintaining it over time by having a soft tissue thickness which is more than that of the natural teeth. When we blow up these pictures after 6 months, you can see then we have no bone resorption, but more than that, we have an increase of bone resting on the implant shoulder. So in time, this emergence profile, which will have which we have developed different than that of the natural tooth, although we use the natural tooth for a temporary, can maintain the soft tissue over time. First, we have to create the prosthetic scaffold for the soft tissue, developing the abutment, which will support the soft tissue almost entirely, and designing the crown for the mid-facial soft tissue support in such a way that this complex of abutment and crown will give enough space for the soft tissue, but also will overcome the biological changes which will occur over time in these cases. In the past, most of the soft tissue was supported by the crown. In specific implant system, the crown emerged subgingivally from the implant shoulder or close to the implant shoulder. That could have more difficulties in cleaning the excess of cement, cleaning the gap which is between the crown and the abutment. And it could also lead to inflammations of the soft tissue, placing different crown materials subgingival. Now, with the help of CAD/CAM material or modified stock abutments, the soft tissue support is almost entirely given by the abutment, which has more advantages, like having the gap between the crown and the abutment at the more coronal level, which makes the removing of the excess of cement more easily.
It's a constant support for the soft tissue, and manipulation by removing and placing the crown can diminish the probability of inflammation. The third is that we place subgingivally materials which are not irritating or are more friendly to the soft tissue, like titanium or zirconia. So the positioning of the abutment coronal junction has changed and developed over time. For the midfacial soft tissue, the design of the abutment becomes very crucial. Now, how should this abutment should be designed for the midfacial soft tissue? A lot of publications in the last couple of years showed that it's better to under contour the abutment facially to give more space for the soft tissue thickness on the buccal aspect of the gingival margin of the tooth. However, in our perspective, the design of the midfacial abutment is depending on the implant position. The buccal palatal implant position is crucial when we're thinking about designing the soft tissue support at the midfacial aspect of the abutments. If the implant would be in the position of the tooth, by having an under-contoured or concave abutment, we would increase the soft tissue thickness for an implant-supported crown versus a natural tooth. However, if the implant is placed slightly buccally, an over-under contouring would also increase the thickness of the soft tissue. In the last couple of years, the implants are placed in the more palatal position, and having the implant in a more palatal position sometimes makes the development of a convex emergence profile on the buccal aspect necessary to reach with this convex abutment the ideal position of the crown. The advantage of a concave emergence profile or a flat emergence profile also permits the reconstruction of the gingival margin, and also by having more thickness of the soft tissue can maintain the soft tissue level over time. The disadvantage of these cases is that from a lateral view, sometimes having a concave emergence profile, we have a collapse of the soft tissue. This picture on the left hand side of this screen shows you an implant in position of tooth number 21 with the ideal gingival margin with the zirconia crown after 8 years in function. In other cases, the disadvantage is a concavity from a lateral view. So from a lateral view, if we have a very much under contour abutment, we have a collapse of the soft tissue with a concavity, and as we know, a concavity doesn't reflect light, so it might shine very dark. When we look at the convex emergence profile at the buccal aspect of the implant, then a convex emergence profile would have advantages and disadvantages. The advantage of a steep emergence profile or a convex emergence profile will lead to a recession of the soft tissue because the soft tissue is going to be very thin. This is only in the case if the implant is placed buccally than the initial position or in the position of the tooth. However, if the implant is placed in the more palatal position, sometimes a convex emergence profile gives the exact or the preferred soft tissue thickness. The disadvantage of a steep or convex emergence profile is that it leads instantly or over time to a slight resection of the buccal aspect. As we know from the literature, in the year 2000 or 2001, every time the recession occurs after abutment and crown connection, after a period of time, and in those days, most of the emergence profiles were convex. If the implant is placed in the more palatal position, then we can achieve the ideal thickness of soft tissue by having a convex emergence profile too. Now, after extraction of a tooth, we will heal, we will have a collapse of the gingival margin during the healing period, sometimes with the loss of height of soft tissue. And if these problems occur over time, we will need a reconstruction will be necessary. The reconstruction will be with the help of ideal emergence profile design with the two components of the transition zone, the abutment and the crown. Now this emergence profile can emulate the natural dentition, can be over contoured versus the natural dentition, or can be under contoured. So if we look and how we can design the emergence profile, we can have different choices. The left hand side we can see a natural tooth extracted where the anatomy is different than the anatomy of the transition zone than the anatomy of an implant supported crown, which would be ideal in prolongation of the root. Then we can see a natural tooth extracted and cut 3 millimeters away from the CEJ line, which is exactly the transition zone which supports the soft tissue. When we design a crown around the implant, these dimensions are changed. We don't try to emulate the emergence profile of the natural teeth anymore. The design is adjusted to the materials we are using and to the changes over time. So we have different options to under contour the midfacial part and over contour the interproximal soft tissue pressure, which you see in the third option, or to under contour everything in the transition zone to give more space for the soft tissue interproximally and at the buccal aspect. So today, when we design our crown, we understand that we don't want necessarily to emulate the emergence profile of the natural tooth because the natural tooth needs less bone buccally than an implant, but also needs less soft tissue at the buccal aspect for a long-term survival and a good aspect. So now when we talk about prosthetic reconstruction of the emergence profile and we thicken the soft tissue development in cases where we have a late restoration of implants versus an immediate implant with immediate soft tissue support. So we have to create the prosthetic scaffold for the future soft tissue support with a temporary abutment or the final abutment with the temporary restoration and the temporary crown. Another option would be to place the final abutment with the temporary restoration when we have to create the prosthetic scaffold only on the most coronal aspect of the gingival margin, interproximally and buccally. So here is an example. The implant is integrated. After delayed implant placement with guided bone regeneration using autogenous bone and some allograft material, the patient had a Maryland bridge in the healing period. This picture shows after removing the Maryland bridge, the healing of the soft tissue. In this case, we have to create now the emergence profile, and we have to create the transition zone from the implant shoulder and the underlying bone to the crown margins, midfacially and interproximally, speak the interproximal papilla. So in this case, we can do a healing abutment at the time of uncovering, or can select an abutment at the time of uncovering. The abutment selection can be done chairside at second stage surgery and placed immediately if it's a stock abutment or if the impression was taken at the time of implant placement. We can place a healing abutment, a temporary abutment, or if we place a final abutment, we have to take a abutment which already has a prepared margin, the correct gingival height, so we can place it at the time of uncovering. This placement of stock abutments with a prepared margin or not gives little option of correction for soft tissue development. So we can use a stock abutment, a stock contour abutment, an individualized stock abutment, a UCL abutment, or a CAD-CAM abutment. We are preferring to get the ideal emergence profile in the lab first, then in the clinic, and then scan this abutment and create the final abutment for the patient. So in a case like this, we prefer to have a healing abutment first, which is much under contoured. We take a healing abutment with a diameter of 3 to 4 millimeters after we, at second stage, after we anesthetize the patient and open the implant. So after we are placing our healing abutment, we can exactly then form the emergence profile of this patient. So first we're going to locate this implant position by using a probe which will go and search for the position of the cover screw. After we located the implant position, we are trying to remove the cover screw. This will lead 2-3 turns. This will lead to a blanching of the soft tissue, and then we can see exactly where the implant is positioned. To open this implant, we can then use a blade or even a soft tissue punch. We will do a very small incision following the contours of the soft tissue, then remove this healing screw, the cover screw, and then place a healing abutment on the implant. We prefer to place a narrow healing abutment to have enough space and enough soft tissue to create afterwards. What we can see that in these cases where we have enough keratinized gingiva from the mucogingival junction to the gingival margin, we can follow the contours and don't have to do any soft tissue manipulation like papilla reconstruction technique or a split thickness flap. So we can see that with very small incisions we are able to remove the cover screws and place a healing abutment. First, we tried to place a healing abutment which can resemble the emergence profile, but then we will change this healing abutment to a much narrower one. So we can see after removing of the cover screw, we can place a healing abutment in position which has a narrower diameter. Okay, 3 weeks after uncovering of the implant and placement of the healing screw, we can observe a good healing, good quality of the keratinized gingiva. After removing the healing abutment, we can see the soft tissue thickness, and we can observe the tissue we have to work with. In the interproximal space, we will have to compress the tissue to develop the papilla for the future contact point. For the midfacial, to avoid recession, we can have an under-contoured emergence profile, which will maintain the observed concavity, but also we can change the dimension so we can have an ideal soft tissue thickness and avoid any future recession of the midfacial soft tissue. Then we will go ahead and take the impression of the abutment fixture with the help of an open tray impression using a very narrow impression coping. It's essential that we don't try to take the impression with a wider impression coping, so we can develop our emergence profile in the laboratory with the help of the cast. In this case, we take a tray, modified stock tray, which we perforate, and the impression is taken with polyether. In this particular case, it's Impragam. Then after the impression is made, we can make our cast, which resembles the situation in the patient's mouth if we take adequate impression copings, which will have the same diameter as the healing abutment. The abutment selection is then made in the laboratory according to the location of the implant, if it's in the aesthetic zone or in the non-aesthetic zone. The abutment is selected according to the gingival height, according to the emergence profile design, the implant depth, the implant vestibulopalatal position, the implant angulation, and the periodontal biotype of the patient. What's very important is that this abutment selection, if it's done in the lab, especially in the aesthetic zone, has to be taken very carefully so they don't harm the soft tissue and don't provoke any modification at the soft tissue level. So what you can see, observe here is that in this specific implant system in BioHorizons, we can take the 3-in-1 abutment, which is an abutment which is delivered with the implant. After the period of osseointegration, we can reuse this for a final abutment, or we can make an individualized abutment out of pattern resin on the 3-in-1 abutment. In this case, we can make a pattern resin sleeve, which is then can be laser welded on the 3-in-1 abutment, or this can be scanned after the try-in in the patient's mouth, so we can treat the patient or restore the implant with the help of a CAD/CAM abutment. We prefer to try in first a lab-made prototype of the CAD/CAM abutment so we can observe the modifications which take place when this abutment is placed in the patient's mouth. So we have to be very careful when we do that, where we position the coronal extension of crown abutment junction, which should be 0.5 to 3 millimeters submarginally. This trying of the emergence profile, which is produced on the 3-in-1 abutment, is then placed in the patient's mouth so we can see the reactions of the future abutment at this specific patient. We place first the prepared or reduced 3-in-1 abutment, then this pattern resin sleeve is placed on top of it, as we will observe in a following film. Then we can check the pressure in the interproximal space, which the final abutment will have to the soft tissue. We can see a slight blanching of the tissues around this abutment. In a recent publication from 2013 from a group from Bern, they say that the blanching shouldn't be more than half of the neighboring teeth. In this case, we see that the whitening of the soft tissue is just about the abutment. Here you can then see that from this we can then laser weld this sleeve onto the 3-in-1 abutment, or scan it and CAD-CAM it. In this specific case, it was laser welded to the 3-in-1 abutment. And then we know the reactions of the final abutment in the patient when this abutment is finished, as you can observe in the last picture on the right side. Then this abutment is tried in the patient's mouth, and we can observe the same reactions at the soft tissue level as we had with the trying. This is also at the level of the papilla, but also at the level of the midfacial soft tissue. Now we have a lot of publications which show us the predictability of the papilla. In a paper by Chu, they measured the papilla proportion in a maxillary anterior dentition, and they found out that the papilla length is approximately 40% of the crown length of the natural tooth. So when we go ahead and use in our patients these dimensions described by Chu and co-authors, we will place the contact point at the maximum height of 40% of the crown height. So usually we do that with less percentage. So here I want to share with you a movie which shows you now the 3-in-1 abutment on the prepared cast. You can see that the cast is prepared in such a way that will resemble the ideal emergence profile. Then we will have a pattern resin sleeve which slides on the reduced 3-in-1 abutment, and we can see two signs on the collateral teeth which shows the level of the papilla, which is less than 40%. Now the two parts are tried in together in the patient's mouth. First the abutment, and you can see now that the discrepancy between the abutment diameter at this point and the future emergence profile, this soft tissue will be moved in the ideal position under pressure, and at this moment we can still modify our abutment according to our needs. If the implant is placed in the more palatal position, we can have it convex. If it's in the right position or in the position of extracted tooth, it can be straight, and if the implant is more buccally, we can under-contour it. At this moment we can already check what will be the reaction of the soft tissue according to our future CAD-CAM or laser welded abutment in the patient's mouth. Here we have the situation without the healing abutment, and then we can check the situation with the final abutment, which will be identical as our try-in when we gonna place this final abutment in the patient's mouth. What you can also observe is how the crown will close down at the gingival margin and which is the effect of the crown margin at the midfacial soft tissue. And again, on the model side, we can observe in a cross-sectional model aspect the thickness of the remaining soft tissue from the buccal aspect of the abutment to the buccal side of the gingival margin. And as we can observe, it's about 2 to 3 millimeters with a convex emergence profile of the abutment in this case. Then this final abutment is placed into the patient's mouth. We can observe the position of the implant looking at the chimney and the screw, and also how this abutment will compress the soft tissue interproximally and give enough space for the soft tissue buccally, although the abutment shape is slightly over contoured. The rest of the soft tissue formation in its final position will be given by the design of the crown, which will compress the soft tissue mostly interproximally and very slightly in the facial aspect. And facial aspect of the abutment in position after removing the temporary crown, as seen as on the screen on the left side, and we can already observe the contours of the soft tissue and the shaping of the interproximal papillae by the temporary crown. So most of the soft tissue support of the midfacial soft tissue is done by the abutment, and interproximally it's a combination of the abutment and the temporary or the final crown. So now when we are placing this abutment in the patient's mouth, we can observe the same reaction at the level of the soft tissue as we observed it with our try-in. At the level of the chimney and the screw axis, we can put some light curing material to protect this chimney from overflow or from the cement with which we will cement our crown in. So when we look at the aspect first, we're going to reduce that, and then we will position our temporary crown at this level. After placing the abutment in the final position, the crown is then cemented, and as you can observe in the movie, it will be very easy to remove the excess of cement. In this way, parts of the crown will shape the soft tissue coronally of the abutment, but in the transition zone, the crown and this abutment function as an entity to be able to develop the soft tissue interproximal, but also develop the soft tissue at the facial aspect. Here you can observe the final outcome of the crown of the left central incisor, but more the soft tissue, the peaks of the papilla with the smile of the patients. In this case, we were able to demonstrate how we can predict the soft tissue outcome by having a prototype of the final abutment made in the lab
prior to CAT cam it or to cam it, or prior to place the final abutment in the patient's mouth. Now, we were talking about different designs of emergence profile at the buccal aspect. The emergence profile can be straight, concave, and convex. If we look at the emergence profile of a natural tooth, sometimes the part of the tooth which is close or which is apical to the CEJ line, 2-3 millimeters apical of the CEJ line, is the part of the tooth which supports the soft tissue. Many times, if we try to emulate or imitate or resemble the natural tooth with a crown on an implant, this soft tissue will not stay there for a long period of time. That's why, depending on the implant position, we can have different emergence profiles. When the soft tissue buccally is thick, the emergence profile of the crown can be the same as that of a natural tooth. If the implant is placed more buccally, we recommend under contouring, and if the implant is placed more palatal, we recommend a convex emergence profile. So here we can see that the final crown, which was made a couple of years ago, which will support the buccal soft tissue. So here are different aspects of the crown, of the gingival margin, and how this crown will sit at the level of the abutment. So a straight buccal emergence profile is recommended when the implant is in the position of the extracted tooth and the soft tissue thickness is adequate. After 7 years, we can observe this case, which was done with the help of aesthetic buccal flap, immediate implant placement with guided bone regeneration using the aesthetic buccal flap design, which we published 7-8 years ago. We can see that the soft tissue can be maintained over time with a straight emergence profile, which can emulate the margins. The papilla level can be maintained and no recession is observed, although we had big surgical intervention at the buccal aspect of the tooth, and we can maintain the soft tissue with a straight emergence profile. When we look at the tooth before implant placement, we can see that we have a periapical inflammation. This was taken care of with the surgical intervention, and after 7 years we can see that the implant is placed at a deeper level. The periapical inflammation was curated in 2004 and everything was cleaned with the help of aesthetic buccal flap, a surgery which doesn't have any circular involvement in the soft tissue, and it means to maintain the soft tissue and the gingival margin during surgery. A convex emergence profile is indicated when the implant is positioned more palatal in the cingulum position or in a position between the cingulum and the incisal edge position. In this case, we can observe that we have a patient with a high smile line, and we have to be very careful with the implant position. The implant is positioned immediately after extraction in a cingulum position, in a more palatal position, and then when the implant is also integrated, we have to develop the emergence profile by making a convex emergence profile, over contour it so the abutment will come in the ideal position of the margins. So this convex abutment will push the soft tissue outside, but not too much, so which will give enough soft tissue thickness which can resist due to the biological changes. So we can see
This is the abutment, the ideal emergence profile, which is convex and not under contoured and gives still enough space for the soft tissue support. Then this is CAD cammed after we are doing a trying of a pattern resin abutment, which will show us the ideal soft tissue support, being sure that there is no alternation at the soft tissue level. Then this abutment is tried in. We also avoid any concavity at the gingival margin level. As we mentioned before, a concavity doesn't reflect light, and that's why many times the patients complain that the tissue above the implant looks dark, although we are using zirconia abutment. This is due to the fact that concavities don't reflect light. Then we can fabricate our full zirconia crown, individualized, and then this crown is placed in the final position in the patient's mouth on the CAD CAM emergence profile. And here you can see in a 3 years follow-up picture that how the emergence profile of the gingival margin looks. Still in the interproximal space we have a dark spot, which is due to the concavity between the implant and the lateral tooth. However, the gingival margin is maintained and is in a more coronal position. That means that slight modifications over time will bring the tissue at the parallel position like the adjacent tooth. Then we have the situation where we have a concave abutment. A concave abutment is indicated when the implant is placed in the incisal edge position and when the soft tissue at the buccal aspect is thin. Many times we are doing a connective tissue graft at the time of implant placement and we want to maintain this thickness of the soft tissue, or we prefer a concave abutment in patients with a thin biotype. In this case, we are using this concave abutment not because of the biotype of the patient, but due to the fact that the implant have to be placed in the incisal edge position, having ideal bone support. Then in the laboratory we try to resemble the zenith and the gingival margin by developing the cast in such a way that the crown on the implant looks similar to the natural crown. In the cast, in the laboratory, we try to resemble with the crown on the implant this aspect of the natural contralateral tooth, and for this reason we have to observe the zenith and the anatomy of the gingival margin so we can modify our model according to the design of the adjacent tooth. Then we can observe in this picture that we have a concave emergence profile. The emergence profile is supported by the crown mostly, because in this case we have the implant in a more coronal position. This concave emergence profile will maintain the soft tissue thickness over time, and it looks like an overlapped pontic which will push the soft tissue upwards. Then we can observe this implant osseointegrated. This is a laser lock implant from BioHorizons, which is in the ideal position. And on the left picture we can see that the gingival margin looks almost the same like the controller tooth. The most important aspect is that we can maintain the soft tissue thickness over time with the help of this concave abutment. Over time we observed that
the shape of this abutment is very important. We can see that having this kind of design of the implant after 3 years follow-up, we have some modification of the contralateral filling of the natural tooth, and we can see that the mid-facial aspect, the soft tissue, can be maintained at the ideal level. As a conclusion, we have to adjust the emergence profile according to the implant positioning. In the interproximal space, when we are talking about the pressure we will have at the level of the papillae, it's almost constant. At the midfacial aspect, we have to adjust the design of the emergence profile in the transition zone at the level of the abutment and at the level of the crown to the implant position for an ideal soft tissue support. So the midfacial emergence profile can be straight, concave, or convex. Thank you very much.